Welcome back, everyone. I hope you've had time to digest and reflect on this morning's proceedings. Our next panel is all about how improvements to infrastructure can help relieve the backlog within the NHS. As many of England's buildings are crumbling and becoming obsolete, in dire need of repair and upgrade, the bill for backlog maintenance grows. This figure has more than doubled since 2020 to 10.2 billion. Half that is rated as high risk or significant risk, with 1.8 billion viewed to be high risk and essential to be renovated. High risk failures that would most likely head towards catastrophic failure, major disruption to clinical services, or risk of serious injury. With the cost of living crisis ever since, the NHS is facing extraordinary inflationary costs, which will considerably impact investment on the estate. The lack of capital investment in infrastructure has also brought resistance to progress. So, to discuss this topic, I'm delighted to introduce you to David Jones, Director of Estates, Facilities and Capital Development at University Hospital Southampton, Joel Glover, Director of Commercial Development at Quality Trusted Solutions, and Isabel Willis, Head of NHS Providers. Oh, I'm getting my voice back there. Hopefully that'll disappear in a minute. Do use the Q&A feature if you'd like to listen to the conversation or you have any questions. You'll find it on the right-hand side of your screen. So I'm just going to pause there because I'm getting my voice back. And see, technically, we can fix that behind the scenes. I don't know if you're guessing that. I'm hearing my voice twice. No, that's strange. Well, in that case, I'll put on. Isabel, while we try and fix this situation, can you start with outlining the two backlogs that we're talking about today, the care backlog and the maintenance backlog?
Yeah, thanks, Ellen. So the term backlog comes up quite a lot, so I think it is helpful at the start to be clear on what we mean. So the two main backlogs that I often talk about are the care backlog and the maintenance backlog. The two are interconnected to some extent. So the care backlog is effectively the secondary care and services which would have been delivered if not for the disruption caused by the COVID-19 pandemic. So that includes patients on a waiting list for treatment, patients had treatments delayed, cancelled, so on. It's important to remember, though, that waiting lists were on the pandemic, but they have grown significantly in recent years because of that disruption caused by COVID-19. In terms of the numbers, the waiting list in February 2020 was at 4.4 million, and the size of the backlog now is just over 7.2 billion. So you can see that rise in those figures. And there are more hidden backlogs as well across community mental health services, for example, which don't always show up in the data when we're looking at the care backlog. So in terms of what that care backlog element means for the NHS, it means it's one of the biggest challenges operationally that we're facing at the moment in terms of recovering from the pandemic. And the service has rightly been set some ambitious targets to bring that waiting list down at pace. And then the second backlog is the maintenance backlog, which you mentioned at the start. That's all around the level of deterioration essentially across the NHS estate. The latest, what's called Estates Returns Information Collection data, ERIC data for short, showed that the backlog, as you said, has risen to 10.2 billion. And what's really concerning, again, as you mentioned, is the degree of risk that's within that at the moment and the trajectory that's been on. So that's the proportion posing degree of high or significant risk has increased to 52%. So we've got this backlog not only increasing in size, increasing in severity as well. And there's a big financial risk that's currently being shouldered by trusts in that. So in terms of what that backlog means for the NHS, it means that there really needs to be this continued focus on capital investment by the government. We've got many parts of the NHS estate in poor condition, and that's putting the safety of patients and staff at risk. And in terms of the interrelation between the two backlogs, if we address the maintenance backlog, it is going to hamper the service's ability to really bear down on those care backlogs at the pace that it needs to and wants to.
Isabel, thank you so much for outlining that so well and so eloquently, and also while I was sorting out my sound issues, which I've managed to do now, which is good. Thank you for starting us off. David, why is the NHS facing a £10 billion hole in backlog maintenance? And is the figure actually 10 billion, or is it more? As well, we're saying there are hidden backlogs too.
Yeah, so the figure for backlog is certainly significantly more in real terms. The ERIC data is based on predominantly 6 facet surveys that are undertaken within hospitals. The cost that is given back in those 6 facet surveys is what's called the book value, and that is without fees, it's without VAT, and a number of charges. So you can effectively double £10 billion in real terms for delivery of that work across the NHS. Why is it so bad? In a sense, the NHS is not receiving sufficient capital to everything it needs, both meeting the clinical backlog in terms of building new buildings, expanding where it needs to expand for services such as excuse me, oncology, etc., which are seeing significant growths, but also then giving money to the large estates to either maintain the infrastructure to the level it needs to, or to knock down and build new buildings. There just isn't enough capital going round. So colleagues of mine, directors of estates, are having to go in front of trust boards and argue the case of funding going to backlog maintenance, where at this moment in time harm may be happening to patients and staff. There is no evidence out there. I'll have to come back to that, but there is no actual evidence out there that patients or staff are coming to actual harm because of backlog maintenance. And we're going against clinicians. They can clearly show the level of their clinical lists are calling patients to cause harm. It's a very tough call for all executives, all directors of finance within the NHS.
It's all tough, and it's all related, as Isabel was saying. I was just looking before I come to you, Joel. I was looking. David from our audience says the answer is simple. It's due to lack of investment. Government clearly agreeing with you, David, about lack of investment, but also Matthew Taylor. I just found a quote here. Chief Executive of the NHS Confederation, that raiding capital budgets to plug holes in the day-to-day spending budget in the 2010s was a massive mistake, and is, one of the reasons why we find ourselves with a crumbling estate and infrastructure. Joel, I'm just wondering, when you're communicating with clinicians about investing in non-clinical areas, how receptive are they to what you're saying, and do they understand that why maintenance backlog is so important, and actually, as Isabel said at the beginning, related to the care backlog? Oh, Joel, will you just turn your microphone if we can't hear you? Start again if you don't mind, because we couldn't hear you there.
I'll try by unmuting the microphone. I think that'll probably
that'd be helpful.
Generally.
You're about as technical as I am on this.
Yeah, just press the button and go. Yeah, so actually, I think in some ways, I find clinical colleagues very receptive to conversations about the fact that it simply isn't at the standard they would like to work in. I mean, if you think about how skilled and expert the workforce is in the clinical space, it's a very highly educated, very highly motivated workforce, delivering complicated work at high pressure. And you would compare it to any other industry where you had, a workforce which you describe in the terms, they'd be working in state-of-the-art that were, fresh and new and really intelligently maintained, and where actually the estates function and all of your enabling functions were really empowered to support those people. And that isn't the case in the NHS. So we spent a lot of time talking to people who are very rightly agitated about the standard of the estate and our ability to hold it in a good place. But I've been in the estates and facilities area for a while. I'm sure that David has got a similar experience where capital investment and estates is the unloved children of the NHS, because at the end of the day, when Treasury looking at the Department of Health budget, the Department of Health is looking down into the NHS and saying, well, hold on a minute, you've had year increases, the budget was ring fenced, during the coalition government, you had year you got cash for the depreciation. Where has all the money gone? And the answer is the money went on revenue pockets. We used it to pay the nurses. Now, we didn't pay the nurses enough. We don't have enough. We don't have enough clinicians in almost any specialty to deliver against the backlog that Isabel's rightly pointed out. But we also don't have enough capital to deliver against capital problems that we've. And it's a real problem, and it does come down to a prioritisation of funding discussion that David's pointed out.
We'll talk about funding a bit later, Joel, in this debate, if we may. Isabel, how are you seeing services affected, and what does it mean in relation to waiting times for patients and also impact on the staff too?
Yeah, so I think trust, certainly with older estates or those that are in need of that urgent maintenance work, tell us about the real difference they've got in actually being able to reconfigure the estate to manage higher levels of activity, to sell up capacity. So that is, a live conversation about how it's hampering their ability to tackle the care backlog as effectively as they'd want to. And with that sort of level of risk across the estate, there is, as David rightly pointed out, the data is not showing that level of the risk playing out necessarily, but there is that inbuilt risk there that it could happen. So I think there is that risk around disruption of patient care as a result of estate issues, and that's a big concern. And I think the impact on staff is actually often overlooked or not really talked about as much. So we do need a safe working environment for staff to deliver their best for patients, but also to retain them. Staff retention in the NHS is really important currently. We don't have enough people. We can't afford for people to be leaving. So just thinking about the environment that people are working in is important. And if you've got buildings crumbling, equipment failing, and ceilings, propped up in one part of hospitals and scaffolding, it's really clear there's a really clear in that detrimental impact on staff, their ability to do the best that they can as well.
And David, building on what Isabel's saying there, can you explain from your perspective what effect a high level of backlog has on services?
Yeah, absolutely. So for us, we are seeing more and more interruptions to clinical services on a daily basis, so whether it's floods, whether it's electrical outages, whether it's issues with ventilation, and those are just the physical elements that we see. I think for me, it goes a lot deeper though. So if you take the recent pandemic and you take ventilation, we do not know how many patients came on, or staff for that matter, because of inadequate or in some cases zero ventilation in wards and clinics around the NHS. And for me, it's how we capture that data and how we move that forward. The BMA published a report at the end of last year talking to their clinicians, and there's about 50% response rate on their clinicians, and they were absolutely clear that this was the state of the infrastructure these days was having an absolute detrimental effect on their ability to deliver the clinical services. But we're not capturing the data, so there isn't a central piece. So every time there is what we call a reactive call that comes in, we don't capture that, and we don't say, well, okay, how much does that cost estate from facilities to actually repair and the time, but also taking one step forward on how long was that service out of use for? So how many beds are we taking out of the reactive requirement because of backlog maintenance, and therefore how many patients cancelled, and what was the impact on that patient? And I think that's something we need to get into a lot on within NHS estates, is how we capture that level of detail, and the ultimate requirement is what is the harm that patients that have been caused.
Joel, I'll bring you in a second because I can see you nodding away there. I just wanted to say that Jane's just messaged in, and you'll have to forgive my ignorance because I don't know what ERIC is, but I'm not sure whether this could be related to what you're saying. Jane says ERIC is a good measure to translate to risk patients and staff. Is this risk recorded nationally and locally on risk registers, please? Does that fit in with what you were saying there?
It does, but you're taking a bit of a leap from the amount of backlog there is, and therefore how it transposes into risk. And really depends on where those clinical services are. So if I have a significant amount of backlog in theatres that is causing disruption and causing delay, that's much bigger concern to me than backlog in patients, as an example, because what affect the immediate service that is required all of the time. There is still a knock-on. So the more that Eric increases, there is a potential for that to increase, the risk to increase. Certainly within Southampton, we have it on our risk register. We have our top risks from our 6-facet survey, and Eric on the risk register. There's very clear visibility from an executive and board level oversight. I don't think that's the case across all NHS organisations, if I'm honest with you, but we need to get into taking that next step from what's on Eric and how it actually translates into patient harm, and we're nowhere near yet.
Jane says that's great, thank you. Joel, you were particularly nodding when we were talking about ventilation, but you were kind of nodding furiously all the way, not furiously as in angry, but not a lot all the way through David. So I suspect you wanted to add to what he was saying there.
I think like there's two things that I wanted to sort of quit. I mean, David's 100% right, as you would expect, right? But I think just from a just general conversational point of view, we have all, I'm sure, been guilty of the thing where you look at a task and you think, I'm a bit busy, I can't really afford to do it yet, and you just leave it a bit, particularly around the house, right? And when you come to do it, it costs an absolute fortune, where you could have done something preventative early on, always costs more. UTS, our principal customers, Central North West London NHS Foundation Trust, it's care, community and mental health services. So we don't have theatres, but what we have is long-term inpatients. With fire recently, we've actually had a couple of fires recently. We had a fire recently. I am not a mechanical person. I'm an accountant, so like don't hold me to this. But those, like the sort of that we had, could probably have been fixed with a higher preventative budget. The that was isn't cancelled activity though. It's we had to spend a lot more money fixing the problem than we would have done if we'd have been able to fix it before we had the fire. Obviously, fixing a fuse board is a lot cheaper than fixing a fuse board and everything that got fire when it went up. But also the psychological impact on the patients. You know, when you've got patients who are in a facility for a long period of time, you need them to feel safe and secure, and disrupting that is obviously very, very profoundly detrimental. What I wanted to say, I think Eric is, I mean, it's torture, but I think it can be a very powerful tool. The problem that we have with basing anything on Eric is that it is retrospective, and so QTS is a host subsidiary. So we have this peculiar perspective that we are in the NHS, but we see the NHS as a customer as well as a commercial entity. A lot of places, Eric is being done purely on spreadsheets, right? At which point you are reliant on a consistency of input year to year into like a spreadsheet that may only be opened once a year over an 8-week period, and then you put in your best guess, put it in. So I was really glad when David was saying, oh, you know, the cost of backlog maintenance is probably double. I mean, I would say the cost of backlog maintenance is probably double and a bit, because David outlined all the things which you have to add on top, and also you have to add on anything that are the sort of, I think we should have known unknowns, backlog out there that we're just not thinking about because it's all done on spreadsheets. You know, and the opportunity there to start moving towards just a 21st century management of a state where we monitor and measure using readily available technology that's out there. Ventilation, airflow, water, air quality, and we actually managed through a pandemic situation. You know, we literally went from cleaning all of our estate COVID, sent the bloke who'd been doing it on holiday for 2 years. He came back, and on his first day we had monkeypox in the trust. You know, we are in a global pandemic era now. We're in a global healthcare system, and we are managing our state like it is still 1950, and that is absolutely no reflection on the professionals. Their hands are tied behind their back by funding and by lack of enthusiasm for change.
We will talk about funding in a second, but very briefly for Carol and for anybody else in our audience who might not be familiar, can you just tell me exactly what Eric is? Carol's asking, Eric question mark.
So Eric is, Isabel mentioned at the start, it's the Estates Return Information system that NHS England manage. If you are thinking to yourself, Joel, that sounds convoluted, it sounds like they've made up the name and then slapped labels on it. Well, this is NHS England, of course, so that's almost certainly what happened. It's an annual report that you do to NHS England based on the previous year. So we're just about to plug in, I think, 22-23 starts soon. You have to load a load of information about your reportable sites. It depends on how many sites you have. So we have 160 sites in our trust. I think 120 of them are reportable. Some trusts have like 1 or 2 sites. If you're just big, like Unitary Hospital Trust, you probably only do 1 report. It's getting, every year it gets more refined. They added 70 questions this year. I think they added 73 the previous year. So it's getting more and more refined. All that does is add more and more complexity to people's spreadsheets that sit on their shared drive for a year. And I actually think that the degree of refinement and drill that's coming along is probably reducing the utility of the reporting at the moment because it's so.
Do you think that, Isabel, with
Yeah, it's certainly got its limitations. We hear that, from our members as well across the board. I think in terms of it is that issue about it being retrospective is an issue, but I think it does give us, just looking at the trend, it sort of is a helpful indicator for us. So it's a helpful barometer in terms of the direction things have moved over the previous year, because it then does show the trend and show that make that case really for trying to stop that trend. So I think, useful barometer, but with limitations.
We do always like examples on these panel discussions. Isabel, I'm just wondering if you've got any of where capital investment is making a positive difference to tackling the care backlog, but across the NHS estate.
Yeah, definitely. So quite often feel like I'm talking doom and gloom all the time. So it's not all doom and gloom, I would stress. So there has been a government commitment to expand the number of community diagnostic centres, for example. So there's been a pledge to open 160 of this by 2025. There's also been a commitment around the number of surgical hubs that are across the country. So the idea there is around both transforming diagnostic care and also ensuring that more patients receive the care that they need. So those things are more, in train to be seen, but I think there's positivity there, and there's definitely drive and a commitment. And then if we're thinking about more broader examples of how trusts used capital or intend to use capital to transform their estates, most of it's around modernising facilities, improving efficiency, reducing carbon footprint sometimes as well. So it might be, in terms of the examples that we see, so it might be investment in urgent treatment centres, discharge lounges, sort of thinking about those problems that are manifesting at the moment in terms of operational pressures like patient flow, and updating facilities in order to really tackle that. So quite a few different examples and work going on, but lots of it is to be seen in terms of what it's going to deliver.
David, of course, funding is key. It's vital. How can we, the $6 million question, how can we reverse the current position?
So unfortunately, that is a bit doom and gloom. So it's not going to be an easy thing to do. If I was given my backlog is currently sitting at £160 million. So if I was given all of the money that I needed tomorrow, it would take me years and years, because we still have a hospital to run, and that's the biggest thing. So my trust has aligned with the work that I'm doing. And just to cover off a comment Joel made about Eric on spreadsheets, we need to be doing within the NHS, we need to be doing proper 6-facet surveys that give us an annual update on where our estate is, that then feeds into Eric and then feeds into New Model Hospital. That's the only way that we'll know how our estate is reacting and how the money we are currently investing is actually helping bringing down that backlog overall. Aside from inflation, of course, which seems to be battling us against us at the moment. But I think for me, NHS needs to really focus on the significant and high level risks in every organisation and within every ICB, and look at what what the true impact is going to be on the patient and the staff if we don't do it, and then look at whether we actually need to be closing facilities down in order to refurbish them, in order to bring them up to standard, and then be able to back up to start bringing those clinical lists down as well. But it is a very tricky one because we are operating in a live environment and we don't have spare wards and spare theatres that we can just move services to while we refurbish the estate that we've got.
David, what keeps driving you? Because naturally that is a bit doom and gloom, but is doom and gloom because the figures are as they are, and you've got a massive black hole and only so much can be done. What keeps you going? What keeps you motivated? Is it because you're in that live situation and your teams are saving lives every day despite the financial hardships and difficulties?
Yeah, absolutely. I mean, I've got an excellent team. University Hospital Southampton. They are all patient focused. They understand that, while the infrastructure is not great, we are delivering world-class care in far from world-class environment, but we are doing what we can with the money we've got and the ability of the services that we've got. So for me, being able to lead that team and lead the development of Southampton into the future, and then when I leave there in how many years' time, to be able to look back and say that I've actually made a difference to the patients and staff that work there.
Keep promising, Joel. We'll talk about funding. Now we are. Where can it be found? What are the step blockers? How can we be creative?
So I'm going to add a bit of doom and gloom to what David's just said. So
I'll go to Isabel for some positivity.
Apparently that's her role in the group. It's terrible.
There's a trend forming on this panel.
So I think it's really important to remember that the new hospitals project is effectively budgeted in. So if you are in an integrated care system which has one of those hospitals nominally coming to you, your capital budget for new build is likely to be spent. At the moment, Treasury have got a completely firm clamp down on any kind of private finance, and so if anyone out there is thinking, okay, well, we'll do something clever, we'll do a sale and lease back, guy, you won't. That will not be allowed. So the only way to invest new capital is to generate what we call CDL, so a capital infusion in year and spend it in year, or do a clever deal with your ICB to get it in and then spread it back out again. It is going to be incredibly difficult to fund capital works. As before, I mean, as David was saying, even if we had places we could get people into, I've got a hospital we'd love permanently closed, but the problem is that it's got beds in it, and if you anyone listening to this who's ever tried to close something with beds in, you're on a hide into nothing with local politicians. We've got a site that is closed. It's been closed for years. It's full of asbestos. Can't sell it because it used to be a maternity. No one's been born in it since before I was born, but we can't get rid of it because it used to have people being born in it. So you're going to have to manage strange little local political pressures and be really careful making and the trade-offs within your system a little bit at a time to manage within the live environment, and that's the hope, I think.
Isabel, what action would you like from the government now?
Yeah, I think there's a few things which speak to what Joel and David were just referring to. So I think there's a theme that's come throughout this, but it is around more long-term thinking. So, the raising of capital budgets in that period that we saw is an example of short-termism, plugging a gap, and then it creating problems that are manifesting now. So I think we'd want to see more long-termism, and that means, in reality, that means a longer term outlook in terms of the capital commitment that the government is willing to put. So extending it beyond 3 years to 10 or more. We have a government capital strategy from the Department of Health and Social Care due to come out last year, I think. So that's been delayed. So I think it would be good to see that come out and for that to have that commitment in it. And also, I think there's an issue around just making sure that as Joel described, that sort of system, that new bedding in of the system, capital allocation system, really can work in the way it's supposed to to. And I think we've got to a point where there does need to be some new thinking around CDEL limits, and how sort of access to capital can actually be reviewed and refreshed, because that's the constant problem that we keep coming back to.
And just finally for David and Joel, integrated regional partnerships, how can they help us reimagine patient pathways to shape our estate? Joel, do you want to kick us off and then go to David, perhaps the final word, if that's okay?
I think they're potentially powerful. I think innovation is potentially really powerful. Come back to me in 5 years and we'll find out if they're doing the things we want them to do.
David?
I think for me, I would want them focused on their pathway. At the moment, we are still very much trust by trust and very protective of our individual trust. We're not necessarily looking at the care pathway across all of the primary through to acute across the ICSs, ICBs. And for me, that is going to have to be how we unlock this, to look at each of the individual care pathways.
And Isabel, do you want to just give us the final word on that, a final thought?
Yeah, it's got to come back to the patient. David summed it up. It's got to be about what do these care pathways need to look like, and what does that how are we going to prevent things? How can we put things in place to really manage demand better earlier on in the pathway?
Thank you so much. Backlog is such an important topic, and it was great to have your 3 voices on today's panel. So, we do appreciate your time. Thank you very much. Massive thank you to David, Joel and Isabel for joining us on the 3rd panel of the day. And thank you to you for being with us so far. I hope you're enjoying the discussions and, of course, finding them useful. During our lunch break, why not try jumping into the meeting hub and build some connections with delegates, not just for this event. You'll have the opportunity to connect with delegates who sign up for future events too. So let's meet back on the platform at 2 o'clock after a well-deserved break, and let the information from this morning's discussions soak in. I'll see you after lunch.